Hello, everybody. My name is Dr. Sharath Krishnaswamy. I'm a neuroanesthetist, and today we shall discuss the second class on transcranial Doppler, the applications of transcranial Doppler. So there are many applications of transcranial Doppler. Amongst the applications, the broad classification of applications are as follows. It can be used in cerebrovascular ischemic diseases. It can be used in perioperative and peri-procedural monitoring. It can be used in neuromonitoring in the ICU, as well as the pharmacological vasomotor testing, cerebral blood pressure autoregulation during liver failure and hepatic encephalopathy and preeclampsia. Moving forward to why we use it in cerebrovascular ischemic diseases. We can use TCD in sickle cell diseases, in right to left cardiac shunts, to identify intra and extracranial steno-occlusive diseases, arteriovenous malformations, and fistulas. And also in the process of cerebral thrombolysis in the acute stroke unit, we can identify the effect of this mechanical thrombectomy or IV thrombolysis. It can be used during carotid endarterectomy, in carotid angioplasty and stenting, in cardiac surgeries to detect microembolus. Especially in the ICU, in the neurocritical care unit, it can be used to detect vasospasm after subarachnoid hemorrhage, to detect raised intracranial pressure in head injury patients, to identify cerebral circulatory arrest and brain death, and intercerebral aneurysm and parenchymal hematoma detection. So this presentation will cover the detection of microembolic signals using the TCD in cerebrovascular ischemia or internal carotid artery stenosis, right to left shunt detection, vasomotor reactivity, and the confirmation of brain death. Now, what is the emboli detection? Embolus may occur in any part of the body, and these are basically particles of solid or air bubbles that travel through the arterial system and into the arteries of the brain. So these air bubbles may clot and occlude the brain's arteries, resulting in a decrease in blood flow, and this can cause a stroke. So these cerebral embolus can be either solid or gaseous, and they may be atherosclerotic plaques or blood clots, and they may originate in the carotid arteries or from the heart. Whereas during certain surgical procedures or during aortic valve surgeries or during decompression, there can be the presence of formation of air bubbles, and this can travel through the bloodstream. So how can TCD be used for cerebral embolus detection? They have a characteristic sound which can be detected by the TCD ultrasound equipment, and they generally have the following characteristics. They have a high spectral energy compared to the surrounding blood flow. They are unidirectional because they can either travel towards the probe or away from the probe. They travel within the bloodstream, hence they appear in the Doppler spectra. They're typically short in duration, and they have a typical chirping or a beeping sound, which makes it different from the standard blood flow. What are hits, which is a high-intensity transient signals, and how are they detected? So the embolus are also known as hits, and many TCD equipment manufacturers use the term hits with relation to the embolic signals. And this TCD ultrasound is widely used to detect and count the cerebral emboli. And this counting or detection of the cerebral emboli, it requires the use of a special head frame, which I will show you in the coming slides, and that is placed on the head. This is when you have two Doppler probes of 2 megahertz Doppler frequency are placed and fixed on either side of the head in the region of the right and the left temporal lobes. And the most common artery that is monitored during the emboli detection is the middle cerebral artery. So this bilateral monitoring helps in obtaining signals from both the right and the left middle cerebral arteries. If you can look here in this Doppler spectra, you'll find a short burst of click, which is highlighted in yellow, which is an indication of this high intensity transient signals. Why would we want to detect this embolus in certain patients? So in patients who have a right to left shunt or patent foramen avail, we can use a test known as a bubble test to detect the patent foramen avail, which is basically a hole between the right and left atrium of the heart. And we can monitor the embolus and also count it during the surgical procedures. The common surgeries which require this sort of embolus monitoring are the carotid endarterectomy and the carotid coronary artery bypass grafting. And it is necessary to do this emboli monitoring in patients with transient ischemic attacks, carotid stenosis, or patients who have a high risk of stroke. How does the International Cerebral Hemodynamic Society describe these microembolic signals? So these are a random occurrence during the cardiac cycle. It appears for a brief duration, usually less than 0.1 seconds. It has a high intensity, which has a greater than 3 decibels over the background. It is a primarily unidirectional signal if you use a fast Fourier transformation, and it has an audible component, that is a whistle or a pop or a chirp. This is the microembolus detection in a patient with asymptomatic carotid stenosis. The upper chamber is an M-mode image of an embolus in the middle cerebral artery, and the lower panel, it shows the high intensity signal in the Doppler channel. You can see here a yellow color streak of light. Besides this visual appearance, you will also hear a clicking sound. Let's say there is a stenosis in a cervical or an intracranial artery. It may produce cerebral ischemia by regional hyperperfusion due to artery embolization or a combination of both. So this will require extended monitoring of an intracranial artery distal to the steno-occlusive site. And this will help us in detecting the spontaneous embolic signals, and it will also help us in quantifying the embologic potential of the atherosclerotic plaque. This is the head frame that I was talking about, which enables a continuous recording of the spectral flow and specifically one particular artery, intracranial artery, for extended periods of time. And detection over a single microembolic signal during 40 minutes of monitoring is considered as clinically significant. This TCD monitoring is also used to detect embolus and to quantify the cerebral embolization. And it also helps in detecting patients who have a high risk of stroke, who have an asymptomatic stenosis of the internal carotid artery. So patients may be treated with dual antiplatelet agents, and the MES count may be reduced after treatment of this possible stenosis with antiplatelet agents. It can either be used alone or in association with clopidogrel. And it can be treated for patients who have extracranial carotid artery stenosis as well as intracranial artery stenosis. Moving forward to the use in the right to left shunt. So the right to left shunt, the patent foramen ovale is the commonest source of it, and it appears in 25% of the general population. And these patients who may develop cerebrovascular ischemia due to paradoxical embolism. And how do we detect whether the patient has a right or left shunt? We can use something known as a bubble test. Mostly a transesophageal echography can be used to detect the right or left shunt, but then we can also use the transcranial Doppler because it is more sensitive and specific than the transesophageal echo in order to quantify the functional potential. We can also use the power motion mode in the TCD machines because it further enhances the sensitivity due to the overlapping and contiguous multiple gates. So how do we do this bubble test? You first establish an intravenous access with an 18-gauge needle into the antecubital vein. You insinate at least one medial cerebral artery. You mix 9 ml of normal saline, 1 ml of air, and few drops of the patient's own blood via a 3-way stopcock, like this. You can mix it by giving at least 10 to 16 strong mixes. And then you inject this contrast media and do the continuous TCD monitoring of the MCA to monitor it for the microembolic signals. After this is injected, how will you detect the right to left shunt? You ask the patient to do a Valsalva maneuver 4 to 6 seconds after the contrast is injected to ensure the arrival of the microbubbles into the right atrium. Now this Valsalva maneuver, it increases the right atrial pressure and it helps in pushing the microbubbles from the right atrium to the left atrium. How do we know whether the Valsalva maneuver is adequate? When there is a 20% reduction in the middle cerebral blood flow velocity, then it indicates that the Valsalva maneuver is adequate. You continue doing the TCD monitoring for another 16 to 20 seconds. And then, since this right to left shunt grade is affected by the body position, you have to do this test in the supine position and the sitting position. So basically, if you have no bubbles in the left atrium, then indicates that there is no right to left shunt and there is no patent foramen or vein. Now that we know how to do the bubble test to identify right to left shunt using a transcranial Doppler, there are different right to left shunt grading systems, and to identify whether the microembolic signal is present or not and to what grade it is in this particular patient. And we can also identify whether it has been decreased after an intervention. So grade 0 stands for no microembolic signal. Grade 1 is from 1 to 10. Grade 2 is when you have the MES count of 11 to 30. And grade 3 is when you have an MES count of more than 30, which are shower or curtain appearance. This is by the international consensus criteria. There is another scale known as the Spencer's logarithmic scale, which has grades from 0 to 5. 0 meaning no MES, grade 1 meaning MES count 1 to 10, grade 2, 11 to 30, grade 3, 31 to 100, grade 4, 100 to 300, and grade 5 if the microembolic signal count is more than 300. Moving forward to understanding how the transcranial Doppler can help in identifying vasomotor reactivity. So the vasomotor reactivity, it represents the response of the cerebral circulation to vasomotor stimulus. So basically, if you can look at these three figures in the diagram, the baseline peak systolic velocity, the increased peak systolic velocity, and a decreased peak systolic velocity in cases of hypercapnia and hypocapnia. Carbon dioxide is seen as a vasodilatory stimulus to cerebral circulation. So the more the carbon dioxide is present in the blood, the more the partial pressure of carbon dioxide, it causes vasodilatation, and there is increased blood flow in the intercerebral blood vessels. On the opposite side, if there is hypocapnia, that is decreased partial pressure of carbon dioxide in the blood, there would be a corresponding decrease in the blood flow in that part of the brain. So how would we conduct this test of vasomotor reactivity? This is something we can employ the use of the breath holding index. This is described by Marcus et al., where the MCA velocities are monitored during the 30 seconds of voluntary breath holding and calculating the breath holding index. So the patient is asked to hold the breath for a minimum of 30 seconds while the MCAs are being monitored with the TCD. And the breathing is started as a gentle inspiration. The middle cerebral flow velocities are noted 4 seconds after the breathing is restarted. And we use the following formula to calculate the breath holding index. That is, the breath holding index is equal to the end of the breath holding mean flow velocity minus the mean flow velocity in the baseline divided by the mean flow velocity of the baseline into 100 divided by the seconds of the breath holding. So now that we've got the value of the breath holding index, if the value is less than 0.69, it indicates that the patient has an impaired cerebrovasodilatory reserve. And this is regulated by the parasympathetic nervous system. A decreased breath holding index, it shows that there is a failure of collateral flow to maintain the cerebral perfusion in order to identify whether the patient can manage the hypercapnia caused due to the breath holding. It is always advisable to monitor both the MCA simultaneously. And if a patient has flow acceleration in the normal MCA, it shows that the patient has adequate hypercapnic challenge. And this is the expected response in the ipsilateral MCA. So how is this useful for us? It can be used by identifying patients who have a higher risk of stroke amongst our patients with asymptomatic carotid stenosis or previously asymptomatic carotid occlusion. Now, moving forward to understanding the cerebrovascular vasomotor reactivity with large artery stenosis. If you can look here in this diagram, the right middle cerebral artery has a severe stenosis. In panel B, it shows the flow's response in both the middle cerebral arteries, that is the right and the left MCAs, during 30 seconds of voluntary breath holding. So you see a normal flow in the left MCA during 30 seconds of voluntary breath holding, whereas you compare it to the right MCA, it shows a paradoxical reduction in the flow velocities, which shows an exhaustion of this vasodilatory reserve due to intracranial steal phenomenon. This is the reverse Robin Hood phenomenon. Robin Hood phenomenon generally means the redirection of blood flow from a area which receives more blood to an area which receives less blood. A reverse Robin Hood syndrome shows that a redirection of blood flow from the vessel from the area which receives less blood flow to the area that receives more blood flow. So this reverse Robin Hood syndrome is seen in the patient who has stenosis of the middle cerebral artery, and that is something that is not favorable to the general condition of the patient. How is TCD used in sickle cell disease? So as we know, the comparing a patient with a normal red blood cells as compared to a patient who has sickle cell disease, a normal red blood cells are biconcave in shape and can move through the arteries of the person without any issue. Whereas a patient with sickle cell disease has the red blood cells in the form of a sickle and tends to form clumps and further forms thrombosis and stenosis in the flow of the blood. And this thrombosis and stenosis can cause a significant stroke risk, with many patients developing ischemic stroke before the age of 20 years. So this stroke is due to stenosis or occlusion of the distal intracranial internal carotid arteries or the proximal MCA. And TCD helps in identifying children with the highest risk of the stroke and who need the blood transfusion. And this TCD is performed according to the stroke prevention in sickle cell disease stop trial protocol. It uses a time average mean of the maximum velocities of the MCA and the terminal ICA recorded on 2 separate occasions separated by at least 2 weeks. So why would we use sickle cell, the transcranial Doppler in patients with sickle cell disease? Because it helps in identifying these patterns early on, that is detection of abnormal blood flow. Medical interventions can be done earlier and preventive measures can be implemented faster to reduce the likelihood of stroke. And we can start the therapies, appropriate therapies such as blood transfusion or medical intervention to reduce the effects of stroke and to give the patient personalized treatment plans. From sickle cell disease, we shall move into understanding how TCD is used as a supplementary test for the confirmation of brain death. So the clinical evaluation of brainstem functions, as well as the other measures, forms the gold standard for the diagnosis of brainstem death. But if we only use clinical assessments, it may delay the diagnosis of brain death. Especially in centers with organ donation, we will have to comprehensively establish the development of brain death. If you can look here, this is a contrast MRI study showing the flow of blood in the internal carotid arteries, but not so much in the intracerebral arteries of the brain. So if you can see, there is flow here in the periphery, but not in the anterior cerebral artery, the middle cerebral artery, or the posterior cerebral artery. So basically, this is a loss of flow. This TCD can be helped in diagnosing cerebral circulatory arrest in adults and in children older than 6 months. It can also be helped to monitor flow changes towards cerebral circulatory arrest. If you can look here, you can see that the patient has a reverberating signal, and this has to be monitored for at least 30 minutes in both MCAs and the basilar artery in order to avoid false positive findings. A patient will have an absence of brain perfusion, and this can be detected by a reverberating flow pattern, systolic spikes, or absent flow signals. And this identification will help us in diagnosing brain death. So how do we do this assessment if you suspect a patient to have cerebral circulatory arrest? So you will have to document the patient's BP at the time of TCD examination. You assess both the MCAs, starting at a depth of 50 millimeters and a basilar artery of 80 millimeters. If a patient has a positive MCA or basilar artery end diastolic flow, the patient has no cerebral circulatory arrest. If a patient has absent end diastolic flow, then it is uncertain. It is too early or too late to identify this arrest. If a patient has reversed minimal end diastolic flow, it's a possible cerebral circulatory arrest. You have to continue monitoring and document the diastolic blood pressure greater than 50 millimeters of mercury. And if a patient finally has reverberating flow, then the patient has probable cerebral circulatory arrest, and you'll have to confirm it in both the middle cerebral arteries and the basilar artery at 80 to 90 millimeters. So the cerebral circulatory arrest in the TCD of the 6-year-old male who underwent abdominal surgery for perforated bowel, and this was complicated by ventricular fibrillation, and the patient had cardiac arrest and cardiopulmonary resuscitation. So this TCD was performed on the day 4 because the patient had absent pupillary reflex and poor gag reflex. If you can look here, the patient will have alternating flow spectra obtained from the right middle cerebral artery and the basilar artery. And the left MCA shows only systolic spikes, which indicates that the patient had cerebral circulatory arrest. Moving forward to identifying the presence of vasospasm and subarachnoid hemorrhage. So the patient who has an aneurysm and a ruptured aneurysm may develop arterial vasospasm, and it may be symptomatic in more than 25% of the patients, leading to delayed ischemic deficit. So this TCD can be used to detect asymptomatic vasospasm and helps in following the spasm progression and to initiate treatment here. The triple H treatment can be used to treat the patient with vasospasm. And it helps to monitor the effective therapies and to detect the resolution of the cerebral vasospasm. If you can look here, the figure on the left shows the mean blood flow velocity in the middle cerebral artery, which is 55 centimeters per second. Like I mentioned before, it is less than 80, so the patient does not have vasospasm. If here, the figure on the right shows the mean blood flow velocity of 219 centimeters per second, which is a definite indication that the patient has cerebral vasospasm. So this TCD can be used to detect the development of vasospasm after the onset of subarachnoid hemorrhage of about 2 to 5 days after it. It can be used by the treating physician and help to monitor its progression, helps in monitoring the response to therapeutic measures, and it also helps in selecting patients for additional endovascular interventions. This table shows the extent to which the patient has either hyperemia or vasospasm. Like I said, if the patient has a mean flow velocity of less than 120 and the Lindegaard ratio of less than 3, then the patient just has hyperemia. If the patient has a mean flow velocity of greater than 120 centimeters per second and a Lindegaard ratio of either 4 to 5 or 5 to 6, then the patient has moderate vasospasm and hyperemia or moderate vasospasm. But if the patient has a mean flow velocity of more than 180 centimeters per second and a Lindegaard ratio of greater than 6, then the patient can be diagnosed to have a severe vasospasm. Like I mentioned before, the Lindegaard ratio and why it is important. This is the relation of the mean velocity of the middle cerebral artery to the ipsilateral mean velocity of the internal carotid artery. It's basically a ratio between the MCA and the ICA. And if a patient has high velocities of the MCA, it may be due to hyperemia or vasospasm. If the patient has a Lindegaard ratio of less than 3, it's possible hyperemia. If the patient has a Lindegaard ratio of greater than 3, then it's vasospasm. If it's 3 to 6, it is mild or moderate. If it is greater than 6, then it is severe. So this ends the second class on transcranial Doppler. This is a class on the applications of transcranial Doppler. You will find the introduction to the transcranial Doppler in the previous video. Thank you.